Hello, everybody. My name is Fernando Alfonso from the Hospital Universitario de la Princesa in Madrid, and I have the pleasure to chair this PCR webinar on the value of coronary physiology in patients presenting with acute coronary syndrome. So this is just one module of a more comprehensive set of modules addressing coronary physiology in the cath lab that are coordinated by Bernard de Bruin and Nico Pulis. So we should be able to discuss today our understanding of the physiology of the acute coronary syndrome and also patients presenting with chronic coronary syndromes. And we will be reviewing the data, the clinical outcome data, after FFR measurements in patients with acute coronary syndrome. So we are all aware that there are being major and rather provocative studies in this field, and hopefully our distinguished speaker will be able to address and get some insights on this. So basically, my questions for today will be, is invasive physiology different in patients with chronic coronary syndrome from that single patient presenting with an acute coronary syndrome? What is the value of FFR and other invasive physiology assessment in the non-culprit coronary arteries? And is there any role for physiology in the culprit coronary vessel? So this will be a case-based presentation, and I have the honor and the pleasure to have these very distinguished speakers. Firstly, Rajesh Karbanda from Oxford, UK, then Thomas Kibble from Essex, UK, and finally, Thomas Engelstrom from Copenhagen, Denmark. So I think we can start now, and hopefully we will be able also to address the questions coming from the audience.
Fernando, thank you very much for that kind introduction. So over the next 10 or 15 minutes, I'm going to cover aspects of invasive physiology in stable and unstable disease. I'm going to address three key areas. One is, how do the outcomes differ between these, how coronary physiology differs, and some recent insights about acute coronary syndrome assessment. So this is a registry study of over 45,000 patients. And what you can see is that patients on the far right who have had an acute coronary syndrome have an almost 50% increase in their relative risk of a further coronary event compared with those with stable disease. So the biology and the phenotype of these patients is different. This next slide is a small study, but it tells you over the time frame for which those events occur. So most of them occur within the first year after the event, but that risk remains elevated for the subsequent 5 years or so and then tails off. So this is not just an acute risk, it's a risk that is maintained over some time. And Prospect 1 data, which remember looked very intensively at a group of patients with acute coronary syndrome, tells us that although the event rate at 3 years is nearly 20%, and half of those events are related to the original culprit stenosis, the other half are related to non-culprit stenosis. So the patients with acute coronary syndrome are different. They have a higher risk of subsequent events. They have a sustained risk of those events, and it's related to something about the biology of those plaques. And that puts into context how we can and should use physiology in these patients and the implications of that background. So I'm going to present a case. This is a very common case, a patient with a chronic coronary syndrome, a 63-year-old male, refractory angina despite good medical therapy, referred for coronary angiography. I'll let the audience digest this coronary angiogram. You can see the middle panel, the left anterior descending artery with that very large diagonal bifurcating system, and this dominant right coronary artery with that stenosis. The questions really, I'm not going to stop, but I want you in the audience to just think about how you would approach this case. What would your strategy be? We're in a physiology meeting, so it won't surprise you that we proceeded to coronary physiology assessment. And what we see is that the right coronary artery was negative to FFR with a threshold of a 0.8. The LAD in the diagonal was significant, and it won't surprise you that we treated the LAD diagonal with an angioplasty. But the key points are that we know that an FFR physiology-guided PCI is superior to an angiography-guided approach in coronary syndromes. We know that it is safe to treat patients with an FFR of greater than 0.8 with medical therapy. So that right coronary, quite comfortable leaving that, although it looks horrible and nasty. I was comfortable leaving that. And that lesions with an FFR of less than 0.8 are better treated with PCI than optimal medical therapy based on the results from FAME 2. So that's very clear and very apparent. Sorry, and that's reflected in the guidelines for chronic coronary syndromes with these class 1 level of evidence A recommendations for the use of coronary physiology in chronic coronary syndromes. So let's turn now to acute coronary syndromes and why they may be different. Well, we've got to deal with the culprit stenosis and with the bystander stenosis. And physiology has a different role in these. I'm going to show you a case which is an example of a rather extreme phenomenon, but it will illustrate the principles. So this is a 61-year-old female with a number of cardiovascular risk factors who presents with an acute chest pain story, an elevated troponin, and no diagnostic ECG changes. This is the coronary angiogram panels. On the upper panels, you see the various views of the left coronary with that mid-LAD stenosis drawing attention and the slow flow in the LAD. The right is dominant and unobstructed, as you can see. And the left ventriculogram shows an anterior wall, a bit of anterior wall dysfunction consistent with a syndrome of myocardial injury in that territory. So this is the angiogram. And again, I want you to think about what you would do with those pictures. Would you stop, reassure, discharge? Would you recommend dual antiplatelet therapy on the basis of the elevated troponin? Would you undertake intracoronary imaging? Would you stent the mid-LAD? The anterior wall is down, there is a lesion. Or would you undertake coronary physiology? Or is there something else that you would do in this patient? We are very conventional in Oxford, and we undertook invasive coronary angiography of the LAD. We felt that was the possible culprit, and that mid-LAD was assessed, and the whole vessel was assessed. And this is the Coroventis output from that study. And you can see that the results there do not suggest any flow limitation. We conducted an MRI study because we wanted to exclude Takotsubo as a possible explanation. In fact, this patient had an established infarction. 2 months later, she presented with classical angina and was referred for angiography. So just think back to the angiogram, think back to what you might expect, and then I will show you the angiogram that this patient then developed. You can see that the mid-LAD lesion looks very similar, but she has now developed a critical stenosis at the ostium of the LAD, which we've looked back at. We could not see any major plaque there. So what this case illustrates, and we treated that with a stent, is that in an acute coronary syndrome, the culprit plaque may not be angiographically visible and may not be flow limiting, but the event rate for these patients is high. In an acute coronary syndrome, I've shown you the MRI, and that can be much, much worse, and that can affect the downstream circulation. And so that has an impact on our use of the FFR or coronary physiology to assess the physiological relevance of a lesion. We can talk about that further in the discussion. So I think you can use physiology in the culprit vessel, and it's fine if it's positive, but actually you need to be cautious about whether you get a negative result, and you need to understand that the biology may mean that other imaging techniques might be better. And this uncertainty of using coronary physiology in the acute coronary syndrome is reflected in the guidelines. You can see here the level of evidence for its use is C and B, and the strength of recommendation is 2B. So this is best opinion rather than a strong recommendation. Okay, if we turn to bystander disease in STEMI, there's a number of studies that have looked at this. And there are two questions really, aren't there? One is, do you treat them or do you leave them? And these original studies looking at angiography guided, leave it or treat it approach confirm that we shouldn't leave malignant bystander coronary disease and just let the patients see how we go. We should treat those. These were superior for that approach. Then we have Dynami and Compare Acute, which was slightly different in that they used a conservative strategy, but compared that with using coronary physiology, and they showed a superiority of the physiology-guided approach. And I've shown you what Flower MI was comparing in this slide, and that was neutral, but we can perhaps discuss that. So I think there's good evidence supporting the use of coronary physiology to guide revascularization in chronic coronary syndromes, and that's reflected by the evidence and the guidelines. Coronary physiology in culprit lesion assessment in ACS is a more complex situation, and I've written not. I think you can use it, and it's easy if it's positive, but beware the negative result. And also understand something about the biology of the artery, which is different. And coronary physiology can be used to understand the bystander disease in patients with acute coronary syndrome. So how do we complement and integrate this? I'm going to show you one study, which you may be aware of, and this is really a combination of physiology and OCT. And this is in patients with diabetes. So patients with diabetes have a very increased risk of coronary events. And what this study told us was that in patients who have an FFR negative lesion, actually using, in this case, OCT imaging to identify high-risk plaques, in this case, thin-capped fibroatheromatous plaques, had an almost 5-fold higher risk of adverse events in the absence of those arteries that didn't show this biology. So I think we're getting some insights into how a combination of imaging and physiology might help us to understand better the management of patients with acute coronary syndromes. But I think there's still some uncertainty about how we best address these high-risk plaques. Is it aggressive medical therapy, or are there other alternatives that we might consider? I don't think we have evidence for that yet. So in conclusion, I think the outcomes differ. There's something different about these patients. That impacts on the use of physiology, and understanding about the plaque rupture and the role of imaging is important. And I think we're now beginning to understand something more about where physiology can be used, specifically for for non-culprit lesions, but understanding that actually a positive FFR is helpful, but a negative FFR vessel might need further assessment. I'm going to close there, and I can open that up for discussion.
So thank you very much, Rajesh. Beautiful talk. As far as I can see, there is no question coming from the audience. So perhaps I will have a couple of questions for you, and perhaps I will ask also the other experts to ask you some questions. So my question will be, if you are facing a patient with an acute coronary syndrome, let's say that the clinical and ECG data suggest that there is the LED, there is a mild lesion, you do your invasive physiology and there is a negative result. So that, okay, according to your talk, you will use coronary imaging following combined. And what happened if you see a TICFA that was seen in combined, but you don't see any signs of rupture or intracoronary thrombus? Do you think we have enough data to proceed and dilate this lesion, or say perhaps this is something else, as a bystander?
I think at the moment, we do not have enough evidence to recommend PCI in that situation. We know that that confers a high risk, and that's what that study has told us. But as I said, I don't know yet the best management for that. We know that those are high risk, but I think the best management currently would be optimal medical therapy in that particular situation. That's where the evidence is. If there had been evidence of plaque rupture on imaging, then I think it's a different scenario. But I think stenting TICFAs, we do not have the evidence that that's the right approach yet.
Okay, so let's go to the different scenario. This patient with negative PWAs in the anterior wall, mild troponins, there is no TICFA. There is a rupture, there is a tiny thrombus, but this is a very large lumen. So this is the culprit, but by OCT, by angio, and by physiology, there is no severe stenosis. Would you treat it knowing that this is culprit, but still with a beautiful area, by all means?
That's a complex question, and in general, I would not put a stent in that situation. I think again, there is no evidence of residual ischemia. The FFR is negative. I would be reassured by that with a large lumen area, and for me, that would be medical therapy. I'd be interested to hear Thomas and Tom's views on that. But for me, at the moment, that I would treat this with aggressive medical therapy. And I think we've got better with our medical therapy. You know, the outcomes with optimal medical therapy have improved. Thomas, what do you think?
I fully agree. We have no evidence that sealing a non-significant plaque with a stent will improve outcome. And I also think it's worth mentioning that a number of patients that are admitted with ACS actually are medically naive. So in these cases, the addition of dual antiplatelet therapy and statin treatment would probably be what will help the patient to avoid future events.
I think Thomas's point about the naivety to medicines is a really actually important one. And I think that these types of cases, you can only take them on individual merit and make a personalized risk and benefit assessment as to whether you implant stents or not. Because the slight corollary is, of course, is that with a stent implantation, you then have a more defined outcome. Because you know what the risks of a stent are long term. So you exchange maybe an uncertain outcome for a more certain one. But I think the naivety of medicines is really important. And you're right, we must not underestimate the powerfulness of the medicines we have in our armory now.
And I think Prospect 1, although it's an old trial, helps us to understand that actually a lot of the subsequent events are driven by minor plaques. I mean, there are lots of TICFAs. There are lots of other, in inverted commas, unstable coronary plaques, and often multiple vessels. If you study the other vessel, there's good historical data that there's often unstable plaques in the other vessel. So I think the mainstay has to be aggressive medical therapy in the absence of physiologically limiting disease.
Okay, so we all agree with that. I think we can move on to the next presentation. Thomas?
Yeah, thanks very much. And thank you for the invite. My name is Thomas Keeble. I'm a cardiologist at the Essex Cardiothoracic Centre, just outside of London in the UK. I'm going to present a very pragmatic case-based discussion, a little bit like Raj's, but with some variation. So I'm going to go on and talk about how we can use physiology in the culprit vessel, in the ambiguous culprit vessel, in the non-culprit vessel, and then talk about adjuncts to physiology, including intravascular imaging, because we need all of these in our armory to give the patient the best possible treatment. So this gentleman is a 56-year-old male who comes to our cardiac centre actually with a hypertensive crisis. He's got blood pressure of 200, but he also has ischemic sounding chest pain at the same time. He has a background of hypertension on treatment, clearly not very well controlled. He's a smoker, he's a non-diabetic, and no past medical history. The ECG is very abnormal with left ventricular hypertrophy and some anterior change and some T-wave inversion. And I think we'd all agree that we suspect that there is clearly some left ventricular hypertrophy related to his hypertensive heart disease. But at the same time, with a history of ischemic sounding chest pain, it is highly likely there may well be an acute coronary syndrome. His echocardiogram is grossly abnormal with left ventricular hypertrophy, a very thick ventricle, and I think it's fair to say global impairment with an ejection fraction of 38%. This is a very abnormal ventricle for a relatively young man. His troponin was elevated at 81, and normal for us is less than 14 with high sensitivity troponin, and otherwise his bloods were unremarkable. He went directly to angiography, and I hope that you can see here that the LAD has what appears to be a tight stenosis and a fairly ugly looking lesion angiographically with an aneurysmal segment into the diagonal. And there is what appears to be most likely a non-culprit moderate lesion in the circumflex. These are both highlighted here. So my plan was realistically to interrogate both physiologically and with imaging the LAD, and then to physiologically interrogate the circumflex after treating the culprit. My eyes were then drawn to the proximal segment of the LAD. While I thought that the sort of mid-segment by the diagonal was the likely culprit, the proximal LAD clearly has a moderate lesion, and I didn't want to ignore that if it was physiologically significant. And the right was unremarkable. So the first thing that I did was put a pressure wire to the distal LAD. And my purpose of doing this was to see and to confirm, to be fair, that the vessel was clearly a significant physiological lesion that I should be performing percutaneous intervention upon. And you can clearly see from the spot RFR, this is an ischemic vessel, as we would expect from the angiographic findings. We then, with the wire in the same position, did a full physiological study. And the reason for me doing this was that I wanted to understand what the IMR was, given the LV dysfunction, given the hypertensive heart disease, because my feeling was both as a culprit, it could be elevated, but given his underlying cardiac pathology, it could also be elevated. But I was glad to see that the IMR was normal, with obviously a very positive vessel. So the reason for doing that also was then my feeling was that I could actually make some assessment with an RFR pullback, and actually with the current technology we have, 2 spot RFRs, to determine if I really thought that that proximal segment was physiologically significant. Clearly, if there was a large step there, I would want to treat it with a stent. But if it was, if there was no real step at that proximal segment, I was pretty comfortable to leave the level of aggressive medical therapy. So I then performed a spot RFR, just distal to that proximal segment, but in between the 2 segments. And I do think that resting indexes in a pullback fashion do have value, and that is certainly my clinical practice. And you can see that it was clearly negative with only a step of 0.03 across that proximal segment. So I was pretty comfortable that I could leave the proximal segment alone and just focus and treat the culprit. I went on to OCT. I wanted to have a look at the features of that LAD. And as can be seen on this pullback, just after wiring the vessel, there is clearly a tight stenosis, as we see on the angiogram. There's a huge plaque burden. There's an aneurysmal segment just there. There's some high-risk features, and I think there is some laminar thrombus just there too. So there was no doubt that this vessel was the culprit and that this lesion needed treated, and that the proximal segment was more modest and certainly physiologically could be left alone. So in keeping with both the physiology and the OCT images, I wired the diagonal. You could see there was a lot of disease around the diagonal to protect that, but they did not require treatment. And then I proceeded to pre-dilate the LAD with a 3mm balloon before stenting with a 23mm Zions 3mm stent across the LAD and leaving that moderate segment proximally, leaving that alone for aggressive medical therapy. So I was pretty happy at this point with the stent result. The diagonal looks as if the flow remains good and brisk. I think it's almost impossible to oppose the stent at that aneurysmal segment, and I did not make any attempt to do so with a semi-compliant balloon. And I was happy that my stent, certainly angiographically, was well deployed with a step up at the front and back end. And I went on then to further assess it with OCT. I won't show you the full runs, but again, I was happy that the stent was well expanded, well deployed, and that didn't require aggressive post-dilatation at any point. At this time, I went on to reassess, and again, pragmatically, I think when we've done physiology to assess a lesion and then decided that we want to treat it, I think it's really important that at the end of our treatment that we actually assess that we've done the job that we set out to do. And there's emerging data to show that we must do a post-PCI check to check that our vessel is optimized and that we haven't missed disease that is physiologically significant. The spot RFR in the distal LAD was 0.92. And we then went on to do a further study to get the full physiological assessment with adenosine and microvascular functions. And that revealed that, as we saw before, the IMR is completely normal, so less than 25. It was 10. The CFR is a very reassuring, greater than 5 liters per minute. And we can see that the FFR in that treated vessel is 0.85. And I have to say, given that and given what I would have to do to the proximal segment and or post-dilate my stent aggressively, I felt that I'd got a pretty good result in what I set out to do. And so at that point in the culprit, I stopped, and I was happy that I've achieved a decent physiological result. I think it was also backed up angiographically. Again, I'd already done an OCT, so I knew that from intravascular imaging, it would look extremely acceptable. But at the same time, angiographically, I was very pleased. And so I then came to, with the same pressure wire, I've used the pressure wire X down the LAD. I just pulled the pressure wire back and redirected it into that high OM branch, which you can see has at least a moderate stenosis, which, to be fair, my experience again in circumflex territories is that the circumflex is very often physiologically physiologically not significant, often because of the territory that it's subtends. But at the same time, I felt it was important to assess this. So the pressure wire X was passed to the distal OM. And you can see with resting indexes, which I use routinely, was clearly strongly negative at 0.95, so above the threshold. And then with adenosine, although I did not do a full IMR CFR study, I didn't think that was necessary in this vessel. The FFR was 0.87. So again, clearly allowing us, as Raj talked about in his lovely talk about the data, we're in very, very safe grounds to leave this vessel alone with aggressive medical therapy, which of course is an absolute mainstay of his treatment. So, in summary and interpretation of this case, I hope I've shown that culprit vessel physiology can be important. And again, as Raj indicated, if it is low, then it's easy. You treat the vessel. But the problem is that if we do have microvascular dysfunction, which we do not have in this case in the culprit, then we know that we can get a false negative, and that then causes more challenges. And then we may well need to use intravascular imaging to help us decide further on whether we should actually treat the vessel or leave the vessel for aggressive medical therapy. I think the combination of both intravascular imaging with physiology was extremely useful in this case. And the two together actually provide us with the best possible information to make the right possible answer for this patient and treat them in the right way. And I think there's no doubt about it that non-culprit vessel assessment is shown to be valuable. And I think in this chap gives us rewarding data that we can safely leave him alone. I really like this. I think all of us look to have schematics and ways of working to aid us to make decisions in the catheter lab. And as we said before, we need to individualize decision making to the patient that's in front of us, knowing the history very well, knowing their medications, knowing their risk factors, knowing their intracoronary imaging and physiology to make the decisions properly. But I really like this coronary review in ACS of physiology by Scarzini, the Oxford group, published last year, which essentially tells us that, look, in STEMI, in the infarct artery, physiology can be very helpful. If the IMR is above 40, we know they fit into a group of patients that will do worse and will have more heart failure. If we then look at both STEMI and non-STEMI, and we want to physiologically assess those vessels, if the vessels are physiologically significant, then it's reasonable, in line with guidance, to treat them. Of course, as Raj and my case have also shown, if the vessel is negative, one needs to be careful if we think it is the culprit, because it can be because of microvascular dysfunction. And so in these two groups, we need to be very, very mindful. And so if it is negative, you may need to, in non-culprit vessels or culprit vessels, use imaging to further assess whether you need to implant a stent or not, as the discussion we had previously. So my final conclusion is that physiology can absolutely help us in acute coronary syndrome, both in the culprit in STEMI, potentially in the culprits in non-STEMI, but also to guide our therapy better. And as I say, I would potentially use this very nice schematic to support your decision-making as a tool in the catheter lab. Thank you.
Okay, excellent talk again, and very controversial issues raised. So from a practical point of view, Tom, I would like to know, what do you do in your cath lab? Because, many people may consider that, going to assess IMR, microvascular dysfunction, in a patient with STEMI is a little bit pushing the envelope too much. I mean, perhaps we need to check with the FFR other vessels. Then if I go for IMR before, how do you manage that? Apart from research protocols, we know IMRs got major prognostic value. When do you think this is a must? When do you think you should do that in the cath lab?
Yeah, so I think one of the major drivers for me to want to do a full microvascular study in this chap was because I was really concerned about his LV dysfunction and his left ventricular hypertrophy, which was clearly a very abnormal finding. And it also, once I knew it was within normal limits, it allowed me to use physiology to guide my procedure in the LAD itself by leaving safely, I hope, the proximal segment alone. I think you're right. Research does, IMR is done predominantly in research active centres, and it is not necessarily part of standard of care. However, my argument would be that as we move forward, I think there is many, many more interest in the microcirculation. In essence, when you give adenosine anyway to get an FFR, if your lab is slick and you have an expertise in doing it, which is pretty straightforward, we inject 3 mils of saline quickly and look at the temperature curves very, very quickly. We then give adenosine and do the same. In most labs, this can be done in 3 minutes. I think that there is a move, certainly in our lab, in research, but also in standard care therapy patients, moving towards understanding both the microcirculation and the epicardial circulation. And actually, when you understand both, I think you can then make better decisions for your patients. So I accept what you say, that this is currently a research tool, but OCT was a research tool 10 years ago too. And I think that there's a decent chance over the next 5 years that probably we're going to be assessing the microcirculation and the epicardial coronary circulation in one go in many, many more patients to help us understand how to treat these patients best.
So thank you very much, Tom. Any comment from Thomas or Rajesh addressing this issue? Microcirculation in acute coronary syndromes. Would you do that in the practical setting, or?
I think what Tom has shown is one of the ways that you can be confident about the interrogation of the culprit vessel using coronary physiology. So as we heard, if there is microvascular dysfunction, then the FFR may be false negative. There's also data for the resting indices that if the resting basal flow is higher or disturbed, then that can give you an artificially false result at that time. And I think by using this detailed assessment, Tom has shown that he was confident to use this in the vessel. The other point I think that is relevant is that we don't always know the culprit. We think we do, but actually there are studies coming out that in 20% or 30% of patients, we treat the wrong vessel. You know, if you look at MRI studies, in the patients where it's easy, where you know the culprits, you know, it's obvious, but in many patients, we may not know the culprit. And I think that adds to the understanding of what the relevance of the physiology is in that situation.
Thomas, perhaps a brief comment on that?
Yes, I fully agree. And also, I think that we need to learn more about what's happening in the microcirculation. And the only way we can do that is to on a more regular basis measure IMR. And I fully agree with Rajesh that we sometimes believe that we have got the culprit, but have not got it and stent the wrong vessel. So I think that IMR could be a clinical tool as well in future.
Okay, so we're willing to hear your talk.
Thank you. And actually, I will take up the pointer from the previous discussion right on, because when we are talking about ACS, we are talking about both STEMI patients and non-STEMI patients. And all of the issues around the validity of the FFR values measured in these cases are dealing with what's happening in the microcirculation. And in the case of an acute STEMI, you have a very large jeopardization of the microcirculation. So in these cases, the culprit lesion cannot be assessed by means of FFR, although this is not a very delicate situation because you should reopen the vessel and stent it anyway. But that's just to say that when we are talking about studies on STEMI and complete revascularization guided by FFR, we are talking about the non-culprit lesions. In non-STEMI, it's a different case. As you know, biomarkers are often very slightly elevated, and this illustrates only that the microcirculatory jeopardization is very minor, and therefore, in general, we believe that you can use the FFR values obtained in non-STEMI situations. So I'll now go on to the STEMI studies that have addressed the issues of physiological guidance of PCI treatment in ACS. Now, 40% of STEMI patients have multi-vessel disease. And the question, of course, is how to deal with the non-culprit lesions. This study shows you that there's a clear benefit from complete revascularization when you compare it with infarct-related artery vascularization only, the clinical endpoint being death, MI, and the need for urgent subsequent revascularization. Well, some may argue that the urgent revascularization only covers the facts that in the IRA arm, you leave untreated lesions and the patients then come back for the treatment of these because the doctors know that they're there. However, if you look at the frequency of admittance for angina, there's no difference between the two groups. The Acute trial we already heard about, it showed that FFR-guided complete revascularization in STEMI patients was in favor in comparison with infarct-related artery PCI only. So that was in conjunction with the previous study, the Dynamic 3 trial. This slide shows you that the investigators have taken all of the FFR negative lesions that were left untreated due to the protocol and divided them into lesions with FFR values above 0.88 and being between 0.80 and 87. And they found that there was equal outcomes if you put your FFR cut point to 0.88 in comparison with what you could call a gray zone between 80 and 87, indicating that probably in ACS patients, the cutoff value of 0.80 is a value cut point. But both the Compare Acute trial and the Dynamic 3 trial have been criticized for this, what you could call a halfway soft endpoint because of the component from the subsequent additional revascularizations. So this meta-analysis shows you on a hard endpoint being death and MI, in which all of the, at that time, present studies that investigated this issue showed that there is a favor of complete revascularization in the case of an outcome being MI or death. And this is considered to be a hard endpoint, of course. Now, the latest of these trials was the COMPLETE trial. In this trial, it was also shown that complete revascularization was superior to culprit only, but the complete revascularization was done on the basis of angiography. And therefore now you put into the discussion whether FFR guidance is needed in these cases. But you have to realize that in the COMPLETE trial, almost 2/3 of the patients, 2/3 of the stenosis were angiographically above 80%. And I hope that you can agree with me that in these cases, above 80 to 90% of stenosis, we can eyeball as good as we can make our judgment based on FFR. So that could be the explanation for this. Now we move on to non-STEMI. This is the FAME study, one of the first studies that really showed the impact of FFR guidance in comparison with angiography-guided PCI. Few people realized that 1/3 of the patients in the FAME trial were actually ACS patients. And what the curves shows you is, in accordance with Rajesh's talk, that ACS patients have more events than stable patients. But the benefit from FFR guidance was, on a relatively basis, the same in the 30% ACS patients as in the stable patients. So how do FFR guide the treatment? How do FFR guide you in the treatment of non-STEMI ACS? This is a Scottish trial in which patients were randomized into two groups. Both groups had angiography done and both groups had FFR done, but only in one of the arms was the FFR value disclosed for the operator. And the operators then had to initially, based on angiography, to tell which treatment he would choose. And in the arm, the FFR, one of the arms, the FFR was subsequently disclosed. And in that arm, the operator had the opportunity to change his opinion as to how the patient should be treated subsequently. And what it shows was that if FFR was disclosed, a number of patients that were initially admitted for vascularization was now admitted for medical therapy. And this was the case post-randomization, but it was also the case 1 year later. And in both groups, quality of life was similar. So what FFR does in a non-STEMI patient is that you, and this is completely in accordance with stable angina pectoris, it moves patients from an ischemic group to a non-ischemic group, and therefore from revascularization to medical therapy, meaning that we overestimate by the eye the severity of stenosis, but we have the result, true ischemic, true physiological result after we've done the FFR. This cohort from ACS patients, primarily non-STEMI and unstable angina pectoris, also underlines that non-STEMI patients have more events than stable patients. And in this study, it's actually suggested that the cut point for non-STEMI patients should be moved from 0.81 or 0.80 to 0.84. There is a number of data below this suggestion. But it's not certain that it will help to stent a non-significant, physiologically non-significant lesion, although ACS patients, as we have already discussed, have higher event rates. So you can ask yourself, what is the reason why there are more events in ACS patients than in stable patients with regard to these lesions that are FFR negative? One explanation could be the fact that anatomically complex lesions are more prone to events, and that ACS lesions are more anatomically complex than stable lesions. This study shows you that if you compare residual syntax score in a number of non-culprit lesions from STEMI patients, then there is no different outcome in regard of future events. This tells us that it's probably not the complexity of the lesion, the anatomy of the lesion, that gives rise to more events in the ACS patients than the stable coronary syndrome. On the other hand, the Prospect 2 trial showed us that if you have, for instance, a high lipid Cordenberg index, you're very much more prone to future events than if you have a low lipid core burden index. So in accordance with previous talks, probably the histology of the plaque gives an inherent more prone risk of future events than the severity of the stenosis or the anatomy of the stenosis. So in conclusion, regarding STEMI patients, an FFR-guided complete revascularization in multivessel disease improves outcome. In non-STEMI patients, an FFR-guided strategy is feasible, as shown in the FAME study and the non-STEMI study from Scotland, but it results in a larger proportion of patients that are treated medically, in which PCR is deferred. And event rates in non-STEMI patients with deferred lesions, non-significantly lesions, are higher compared to stable coronary artery disease, but this is probably related to plaque histology more to plaque anatomy or vessel anatomy. Thank you very much.
Thank you very much, Thomas. Excellent talk. I mean, I would like to take the opportunity of your experience with Dynamic 3 and use that to give me some insights on how you will answer people saying, well, we got now flower MI. So that in a patient with a myocardial infarction, I know that just angiographically, I can do as well as using FFR. And sometimes you should acknowledge that, that when the FFR evaluation is not done in the acute setting, because the patient is having a STEMI, well, sometimes the whole team get very disappointed when you see let's say 70% lesion, you bring the patient back to the cath lab, and then the FFR is negative. So that I will suspect that perhaps many people now will say, well, if angiography is as good from clinical standards, I will forget about FFR and other lesions, and I will just proceed. So, coming from Dynamic 3, in your experience, what will be your answer to this resume?
I think regarding severe lesions that went for the complete trial and also the flower MI trial, in which the flower MI trial, more than half of the patients had stenosis severity of above 70%, and many of them being 80 to 90%. So in the case of severe stenosis, I think that you can avoid FFR. Having said that, I have some troubles with the flower MI study due to the low number of patients. They assumed an event rate in the angiographic arm of 15% regarding death MI and repeat revascularization. And if you look into the complete trial, the 1-year rate of this endpoint was only 5%. So the power calculation was extremely optimistic, and I think you should be a little cautious in evaluating the Flower MI trial in that regard. With regard to the timing of the FFR, I'm not certain that there are that many differences between the acute setting of a non-culprit lesion and a subsequent FFR measurement. I mean, after all, they are the more stable lesions in the ACS than the Stemi lesion. But maybe my colleagues have other opinions on this.
How our healthcare system deals with these non-culprits, and I think there is variability certainly across the UK and maybe across Europe. We tend to, I completely agree with Thomas in that if there is a tight lesion, you do not require physiology to support that needs stenting to complete your revascularization. And we would usually, when there is a very severe stenosis, bring the patient back into the lab on the same admission before they go home from hospital. And then if we have a more modest stenosis, a more moderate stenosis in a non-culprit vessel, our standard of care would be that we would usually bring them back within 4 weeks for a second procedure so that we can reassess the culprit that we treated at the time, and then we can physiologically assess the non-culprit, if you like, in the cold light of day. But I accept Thomas's points also that it is highly likely that the physiology at those 2 time points is likely to be very, very similar in the non-culprit. So maybe why not do it during the admission? But I think, to be fair, different healthcare economies and different healthcare systems kind of have different remunerations and ways of doing things. So I think some of the sort of variation is related to that. But I think the key thing is complete revascularization in appropriate patients, whichever way works for your healthcare system.
Okay, Rajesh, we need your comment now.
Yeah, sorry, I got lost for a bit. So I think there are 2 questions. Should we offer complete revascularization? And I think that question is answered. And I think then the next question is about the timing, and we've discussed a bit about that. And I think staged is as good as acute. And then the third question is, should it be angiography or pressure wire guided? And Flower is the first trial to directly address that question. But it has a number of issues in terms of powering, as Thomas has illustrated. The event rate was low, and it was neutral. It wasn't negative, it was neutral. And we're sort of getting this idea of treat everybody with the same approach. And it is about using physiology selectively. It's a little bit like the arguments of using one treatment for everybody. And you have to have a tailored approach and understand where physiology is helpful. It's the sort of, do you do everything or offer them the same patient, or do you do selective physiology? And I think what we're doing with these trials is trying to do a blanket treatment. And I think we need to be more subtle, as Thomas has said. The very severe lesions, many of us would offer treatment for pragmatically rather than offer physiology interrogation. So I think that's the balance of understanding where you need the additional physiology and how we best use that. But I think Flower was neutral, and I think there are, the event rate was low.
So there is a question from the audience basically saying, what about imaging? I mean, we are now concentrating here in physiology, but perhaps many people will say, well, with imaging, we can see whether it's a rupture or perhaps an erosion, perhaps we can leave this untreated, and we can optimize the final result. Well, I think these are different fields, and probably they are complementary in nature. So that I don't think, I would like just to close this and summarize by saying that we got, experts explaining to us the value of coronary physiology in patients with acute coronary syndrome. This was, in my view, a very comprehensive, complete review of what we know. The beauty of this is that while we were listening to all these talks, there is plenty of ideas and plenty of questions, so that we both need to be taking care in every clinical patient, in every patient in the cath lab, to keep thinking. And obviously, we need to keep promoting research to advance knowledge. So I think thank you very much to all the panelists. Thank you very much to the audience, and please keep seeing these modules of physiology, because there are more modules to come from this unique meeting. Thank you very much.
Thank you.
Thank you.